All right, thank you everyone. Good afternoon on this Saturday afternoon. My name is Syed Haider. I'm a fourth-year medical student, and I'll be starting my residency training at Rutgers this July. And on behalf of all the authors, I wanted to first of all thank SAGES and the program committee for giving us opportunity to present here. So first of all, no disclosures. So just to give a little background about the talk itself, minimally invasive approach has become standard of care for many abdominal surgeries for many different reasons. Reduced pain, fewer complications, faster recovery times are some of the most cited reasons for the minimally invasive approach. Current literature has identified racial disparities in access to care received by patients in a variety of healthcare settings. And the reason why this is important is because health disparities are shown to show poor patient outcomes, and they cause a tremendous burden on the healthcare system. However, very little is known about health disparities in context to the minimally invasive surgeries for some of the most common abdominal procedures. So just to talk about what methods and methodology we use for our studies, we used American College of Surgery's NISQWeb database from 2016 and identified four most common procedures: inguinal hernia repair, cholecystectomies, appendectomies, and colectomies. The variable of interest for us were the demographics, the race and ethnicities in particular, and some of the other important ones were the preoperative clinical variables available to all the attending surgeons. For our analysis, we used univariate analysis, chi-square, and t-test squares. And further, to eliminate any undesired bias associated with comorbidities, we use propensity scoring matching, one-on-one matching, to identify racial disparities. Any result that we say are significant is less than 0.05. So just first of all, going through the demographics and patient characteristics of our cohort, from the database from 2016, the 5 procedures were unilateral hernia repair, bilateral hernia repair, cholecystectomy, appendectomy, and colectomy. Here I show the case breakdown, which provided us with a large enough sample size. And on the right side of the graph, we have the percent of Caucasian and Black African American distribution. These two groups were the highest number of patient population in the database, and which allowed us to compare the two. So if you look at, and when we did the descriptive and basic analysis, what we identified in our studies was that Black patients were more likely to receive or less likely to receive minimally invasive approach compared to open surgeries. So here, for instance, if I take an example of unilateral hernia repair, you see that Caucasian, the percent of the patient population that received laparoscopic approach was 26.6%. On the counterpart, Blacks and African American received about 20.1% of laparoscopic procedures, so showing they were less likely to receive the minimally invasive approach. And these are the results for the other procedures described above. And all of these results and values were statistically significant, which means they were less than 0.005. Now, in order to make sure, since our patient population, as I showed in the clinical breakdown, there was such a huge difference between the number of patient population from Caucasian group and from Black African American, what we really wanted to do was propensity score matching. By matching, just because having a large sample size allowed us to do one-on-one matching with the groups. And we used the same 5 procedures, and the groups were balanced for covariance with the exceptions of race, geography, and insurance coverage. And this is a case breakdown of like all the 5 procedures. So the major findings from our propensity scoring testing were, so for instance, in this slide, I show unilateral inguinal hernia repair and bilateral inguinal hernia repair. And we show that the Caucasian and white patient population had significantly higher access to laparoscopic procedures, and both the values were significant. In other words, Black patients were more likely to undergo open hernia surgeries for these 2 procedures. This was also consistent with the other 3 procedures I talked about, and all the values were statistically significant on propensity matching as well. So when we get into figuring out and trying to understand what causes these disparities in surgery in access to minimally invasive, the co-authors and us, after deliberation, think there are three major important reasons why this disparity could be explained. First one is the economic barrier in access to standard of care. The propensity scoring matching algorithm, as mentioned before, does not balance for insurance coverage. And insurance coverage and low socioeconomic status has been shown to be a proxy for race. And the lack of balancing insurance coverage could potentially explain the impact of economics in access to the minimally invasive approach. Similarly, different hospitals and physicians are reimbursed differently at different rates by different healthcare insurance systems, which could potentially play an incredible role in decision-making process. So, for instance, current public insurance system often reimburses surgeons less for performing minimally invasive surgeries. And there was a paper written by Angus and other co-authors who talked about gastric bypass surgeries and how the surgeons were de-incentivized to perform laparoscopic surgeries as compared to open, and a lot of it had to do with the insurance systems and the reimbursement. Second point that we think that's really important and critical is the geographic differences in access to standard of care. So access to the urban and teaching environment hospitals play an incredible role in who has access to minimally invasive surgeries. As shown above, the bigger teaching academic centers have more access to laparoscopic procedures. And since our database, NISQIP database, entails both a national database that has community programs or academic programs, access to big academic centers could potentially explain the differences that we are seeing here. Additionally, the hospital quality and the hospital culture really plays an incredible role in whether minimally invasive surgeries are preferred over open surgeries. And lastly, one of the most important points that has been shown in literature is the role of implicit bias in surgical care. When we think about implicit bias, it doesn't necessarily mean something restricted to race. It could be other demographic factors that could potentially explain the bias in clinical care. And studies have shown, particularly in cardiovascular, that the white and Caucasian patient population are more likely to, so black patients are less likely to be diagnosed with thrombolysis and are more likely to undergo bypass surgeries compared to Caucasian groups. So I think implicit bias, as shown by other fields, could be potentially playing a role in surgical care as well. So in summary, these are the major talking points is that there appears to be a racial disparity in application of minimally invasive surgery in context of the foremost common procedures that we see being performed. We, as authors, suggest that this disparity is multifactorial. It entails economic barriers, geographic barriers, and of course, implicit bias amongst general surgeons. And lastly, we suggest that further investigation into barriers preventing access should be explored so we can design intervention that can reduce the burden overall addressing this disparity. Thank you. And I'll take questions.